Respected panelists, learned audience, Assalamu alaikum and good afternoon. My today's topic is echocardiographic evaluation of prosthetic valve from guideline to daily practice. Assessment of prosthetic valves requires an in-depth knowledge of the types of the valve implanted, hemodynamic profile, and clinical consequences. Echocardiography remains the most easily available, preferred modality of evaluation of prosthetic heart valve. The echocardiographic principles for the assessment of the native valves do not validate it for the artificial valves. Implications of improper approach to assessment of prosthetic heart valves can be catastrophic. A stepwise approach to distinguish normal from abnormal prosthetic heart valve function through echocardiography is needed. First of all, we have to know about the types of prosthetic heart valves. We can first differentiate, classify into mechanical and biological. And mechanical valves includes bileaflet, which means St. bileaflet, single tilting disc, and ball and case, start adored a ball and case valve. But nowadays we usually use St. bileaflet mechanical valves. Biological valves is divided into stented, stentless, and percutaneous, and most of the valve is from porcine or bovine origin. And percutaneous valves can be a balloon expandable or self-expandable like core valves. And when should we do first echocardiography after postoperative prosthetic valve patient? Ideally, a baseline postoperative transthoracic echocardiography should be performed 3 to 12 weeks after surgery, because then chest wound has been held, ventricular function has been improved, and anemia with its hyperdynamic state has been resolved. But there is some limitation and pitfalls of echocardiography in assessing the prosthetic valves, and these are reverbation, acoustic shadowing, proper orientation or alignment, microbubbles, nerval excessive movement, mimicking of aortic root abscess. What are the prerequisites before the echocardiographic evaluation in case of prosthetic valve? Clinical information, symptoms, and related findings, blood pressure, heart rate, height, weight, and body surface area, date of prosthetic valve placement, and type of valve and size of the valve. Like any other echocardiography, we should start with 2D echocardiography, then we'll go colored Doppler and then spectral. First, we have to imaging of the valve from the multiple planes. Opening, we should give our eyes regarding the opening and closing of the leaflets or occluder. Whether the presence of leaflet thickening, calcification, is there any abnormal echo density on the various components of the prosthesis or adjacent to prosthesis? And we should give our a view towards the sewing rings or stent integrity and stability and position of the sewing ring or stent frame. This is the echocardiography of a bileaflet prosthetic valve in mitral position, and these are the normally functioning and normal cardiac chambers. And what are the Doppler echocardiographic tools for the evaluation of the prosthetic valve? These are peak and mean pressure gradient, VTI of the jet, Doppler velocity index, contour of the jet, acceleration time, pressure half time in case of mitral and tricuspid valve, effective orifice area, presence, location, and severity of regurgitation. First of all, we have to measure peak and mean gradient. In the morning, the BKM is beautifully demonstrate how we'll use Bernoulli equation to measure peak and mean gradient. Any measurement, if it is mean gradient is more than 3 meter per second or 20 millimeter mercury in case of aortic prosthesis, and in case of mitral prosthesis, if it is more than 1.9 meters per second or 6 millimeter mercury, then we should think of the prosthetic valve stenosis. But if we found high velocity or gradient alone is not a proof of intrinsic prosthetic obstruction, and we also have to think if is there anything prosthetic patient mismatch, high flow condition, prosthetic valve regurgitation, localized high central jet velocity in bileaflet mechanical valves, and increased heart rate. And they recommend also demonstrate how to measure effective orifice area, and effective orifice area is very important in case of prosthetic valve measurement. And in case of aortic prosthesis, if effective orifice area is less than 0.8 centimeters square, we think it has significant stenosis. And in case of mitral, if it is less than 1 centimeter square, it which suggests significant stenosis. Doppler velocity index is the ratio between the velocity time integral of the LVT flow and VTI of the transprosthetic flow. And in case of aortic valve stenosis, it is less than 3 is significant. And in case of mitral valve stenosis, if it is more than 2.2 meter per second, then it is significant. Contour of the jet velocity signal is important in case of aortic prosthesis. It is normally it is like a triangular shape. If it is become globular shape, it indicated stenosis, and if acceleration time is increased, then it indicates stenosis. Now, prosthetic valve regurgitation. In case of prosthetic valve regurgitation, we have to think whether it is physiological or pathological, because all prosthetic valve has some normal regurgitant volume, because regurgitant volume, this regurgitant volume theoretically prevents blood stresses and thrombus formation. Now, what are the criteria of the physiological jet? Physiological jet is usually thin, laminal, and length is less than 2 to 3 centimeter. But pathological jet, maybe it is perivalvular and it has flow convergence. Prosthetic aortic valve regurgitation, it is very tough and very difficult to do assessment of the severity of the prosthetic valve regurgitation by transthoracic echocardiography. Then we have to take the help of transesophageal echocardiography, because it helps to identify the possible complication like flail by prosthetic cast, presence of pannus, thrombus, vegetation, abscess formation, and dehiscence. The evaluation of the aortic valve, prosthetic aortic valve regurgitation and mitral regurgitation is same like native valve. But as transthoracic view has some limitation in case of mitral valve prosthetic regurgitation, when we should think that we have to do more evaluation with transesophageal echo to see the severity of the mitral valve regurgitation. If we see the flow convergence on the LV side, if the mitral E wave is more than 2 meters a second and gradient is more than 6 millimeter mercury and DVI is greater than 2.2, and nonetheless unexplained or new worsening of the pulmonary arterial hypertension and dilated and hyperkinetic LV. We should also measure and give our attention regarding LV-RV size, function, and hypertrophy, left atrial RA size and function, concomitant other valvular disease, estimation of the PA pressure, venous inflow pattern, pulmonary vein in case of mitral valve, and hepatic vein for tricuspid valve, and previous post-operative study when available. And what are the prosthetic valve malfunction? It's mainly obstruction, regurgitation, infective endocarditis, and prosthetic patient mismatch. Prosthetic valve obstruction is mostly due to thrombosis or pannus. Thrombosis, and we have to differentiate between thrombus and pannus on the background of a history. Thrombosis is a quick history, acute history, and pannus is a long, prolonged history. It is a large and less echodense, mobile, and associated with spontaneous echocontrast, and thrombosis occurs more in mitral valve than the aortic valve. On the other hand, in the contrast, pannus is small, dense, firmly fixed, and pannus has no relationship or less relationship with the anticoagulation, because thrombosis in male patient has a history of discontinuation or inadequate anticoagulation. During evaluation of posterior valve regurgitation, we have to think whether it is a transvalvular regurgitation or perivalvular regurgitation. Here we are seeing a bilateral mitral prosthesis, and here there is a dehiscence and causing severe perivalvular regurgitation. Prosthetic valve endocarditis is the notorious than all type of endocarditis, and it is about 20% of all infective endocarditis, and we are classifying early and late. And Here, the transesophageal echo is more sensitive, and transesophageal echo is very much needed for the diagnosis of prosthetic valve endocarditis. Here is a patient with prosthetic valve endocarditis in the bileaflet mitral prosthesis. And what is prosthetic patient mismatch? And it's very important when effective orifice area of a normally functioning prosthesis is too small in relation to the patient body size, resulting in abnormally high postoperative gradient. For that reason, we have to always index with the body surface area of in case of effective orifice area. And if effective orifice area in case of aortic position is less than 0.6 centimeters square and mitral is less than 0.9 centimeters square per meter square, it identifies severe prosthetic patient mismatch. Now it is story of a 78 years old old patient who he came to us with respiratory distress and fatigue, and he had a history of implantation of biprosthetic valve 1 year back, and we found there is dehiscence, and which was more appreciated in the transesophageal echo, and we have found both the dehiscence and severe aortic regurgitation. This is a story of another middle-aged woman who had a history of implantation of stented biprosthetic valve 2 years ago, and she presented with respiratory distress and fatigue. And we have found she had severe mitral regurgitation, severe tricuspid regurgitation, pulmonary hypertension, and RV dysfunction. And she had also history of permanent pacemaker implantation. This patient presented us in the midnight in the CCU with severe respiratory distress and low cardiac output state. And she had a history of discontinuation of anticoagulation for 2 months. And she noticed the diminution of his prosthetic click. And when we saw there is stuck mitral valve, and when we do the peak gradient, it is about 46 millimeter mercury, and she had severe pulmonary hypertension. And we gave her streptokinase, and after streptokinase, his valves is moving and gradient become lower, which is about 26 millimeter mercury. In conclusion, echocardiography is the imaging modality of choice for the initial evaluation and management of prosthetic heart valves. A comprehensive approach is needed to assess valve structure and function after percutaneous or surgical valve replacement. In general, assessment of the prosthetic valve function is more challenging than native valve because of suboptimal visualization of prosthetic valve structure and occluder device with transthoracic, which can be overcome by transesophageal echo. Serial comparison with a baseline postoperative study is essential in facilitating accurate evaluation of valve function. In addition to the traditional role of 2D and 3D transesophageal in assessing the valve dysfunction, CT and cardiac MR have emerged as the powerful imaging modalities that complement echocardiography. Thank you. Thank you all for giving me attention.
Thank you, Dr. Shahana Zaman.